In indigenous cultures, old age is venerated. You know, this is a repository of wisdom, of culture, time binding. Not in our culture, because in our culture, old people are a joke and an inconvenience.
Getting old isn't for sissies, as somebody said. You have to bear it and learn to roll with it and acclimatize yourself to the change.
We don't dwell on age, we just keep going.
Yeah, I'm going to be 90 years old. I feel like I'm 30.
Oh, I'm not old in mind. I'm just old in numbers. And one of the things I tell people if they try to find out my age, which I may give you at the end, I'll think about it. Everyone says that age is just a number, and my answer to that, if they ask, is age is just a number and mine is unlisted.
It takes a lot of patience to deal with us old folks. It takes a lot of patience. Anybody that does that, I admire them very much.
Following residency, I began practicing in a rural community, and to my surprise, most of my patients were older. It was kind of scary at first, but over the years, that actually became part of the most interesting part of my practice, really, and I became more and more interested in taking care of older people. Found out it wasn't nearly as scary as I thought, being out in a community as compared to a referral medical center.
Among the first 3 nursing home patients that I had 2 of them that I made a huge difference in their lives. You know, I said, wow, these are people that I can make a difference with. This is a group of people that's obviously being neglected, that's not being taken care of very well, and that I can make a huge difference for. And that got me very excited and interested in geriatrics.
It's rewarding because there's not many people who do it, honestly. So if that were to get fixed and there was an abundance of geriatricians, it probably wouldn't be as rewarding as it is being kind of one of the limited few people who really has that expertise. It makes you feel valued and like you can provide something that few other people can.
I think I was drawn more and more to the complex interactions of the diseases themselves and started liking that aspect of it. And I don't know that I can say I was drawn to it immediately. I think it kind of grew on me. And having the right mentor, people that were doing geriatrics, was really important.
And I think that I was attracted by what I saw as a system of care that didn't do a very good job taking care of older people. My first encounter with older people was in the hospital, with them commonly being very ill, oftentimes delirious, their identities being removed from them. It didn't seem like a very respectful sort of experience. So as I got to know older people in my practice, in their families, and then started to do some work in nursing home care, it became obvious to me that somebody needed to do a better job of this. And the environment that I was in at the time, it wasn't clear that anybody was going to step up to the plate.
We heard, this vague stories of this giant bomb being dropped in Japan, and we were all excited. And then one day we hear that a few days later that it's over, the war is over. So we immediately jumped on the train to go into Manhattan. Didn't bother to get passes. We went AWOL to go. And if you look at that nice black and white crazy movie scene of the festivities in Times Square, I'm there. We had guys handing us bottles, say, "Here, soldier, have a drink." And we had beautiful girls coming up and kissing us.
There's tremendous joys associated with taking care of older people. They have had such rich experiences, which, if we listen, they are willing to share.
Recently, one of my patients that came from Germany and was in the era of the concentration camps, and she actually put together this book, a story of her life and where she'd been, and it was a phenomenal read. It just took about 20 minutes to go through it, but it is just phenomenal. And I think if you don't take the time to get to know that about the elderly people, you're just going to lose a lot.
They are just really a fun group of people. And what makes them fun is because they don't have to impress anybody anymore.
There was a patient last week that we're like, you know, how are you doing? I'd fixed his hip, and he, you know, wasn't going to sugarcoat. He's like, I'm not worth a damn, you know. And so they will tell how it is, and it is a pleasure to hear that honesty from people, because they're usually going to say, yeah, I'm not going to do that, you know.
The older population, they don't come into an encounter expecting very much oftentimes, and when it exceeds their expectation, they are incredibly grateful.
If anyone is interested in seeing the whole picture and in working with all elements of the healthcare system, they should strive to work with older people, because just inevitably the needs are so much greater in that group of people.
Rarely are you dealing with one disease entity. Usually you're dealing with somebody who is frail, somewhat decrepit, or very decrepit, who has multiple organ systems that are failing.
They take more time than a 25-year-old with a cough. They take more time than a 50-year-old with a cough or with two problems.
Elderly patients don't see as well, they don't hear as well, they don't handle medications as well, so you need to know their kidney function, their liver function, how the drugs you're giving them are going to interact, because you don't want an interaction that's going to cause them to fall because they're lightheaded or accumulate drug and then not think as well.
People think, well, you know, you don't really get people better. You don't get old people better when you take care of them. Oftentimes they have chronic medical problems. They may have acute life-threatening problems. And it just seems like you're maintaining the status quo. I guess the way I look at that is that there's always something that we can do to help people. And then if we're willing to take on those complicated problems, and if we're willing to work with their family caregivers, and if we're willing to work with other members of the healthcare team in a way that's effective, we can do quite a bit to help people.
Your ability actually to improve the quality of somebody's life is probably as great or greater than as it is any time in the life cycle. So that's, you know, that's fun. That's rewarding.
That's human nature. That's nature. You're born and you die. So when it's time, you don't want to be hung on to, you know, you want to just go.
And so then inevitably, if we are going to advocate for people, care for them over time, through thick and thin, the end will come, and we will have to be good and capable at providing good end-of-life care for older patients. And this means seeing things to the end.
One of the other very rich experiences that I've had in my years as a physician is being with patients and with their families during the dying process, and being able to sort of work through that narrative, work through that rather amazing experience that no one can have like we can have as physicians.
And there are many, many skills that can be acquired that enable us to provide better end-of-life care for people, such that people don't have to die in pain, and they don't have to die in circumstances that they wouldn't wish to be, and they don't have to die alone. And that's the promise that we really should make to everyone, and the promise that we would want for ourselves.
I know that there's been more and more focus on pain management in terms of pain as a fifth vital sign. There's been a lot of discussion on the psychosocial aspect of communication, giving news. I think that some students do have problems talking about death, although I think a lot of it comes with what their prior experiences have been.
I mean, literally, you know, medical students now will have never seen a person die.
100 years ago, you know, where did grandmother die? She died at home. Maybe the doctor came out, the family was around the bedside. There was an extended family, so the kids saw what was going on.
That doesn't happen now, and so we shuffle people off into hospitals or other places where out of sight, out of mind, and they die in a different way.
Whereas I think, now with the palliative care movement, I think a lot of our task is to help patients, as well as students and doctors, to relearn what is natural dying. The color changes we're seeing in the feet, what does that mean? How much time is left? What's going to happen so that it's not a scary unknown?
I've come to look at dying as a real integral part of life, and it's one of those just really intense and satisfying parts of life. To have a good death, that's one of the things I wish for myself, is to have a good death. And what does that mean? What makes a death good? What makes it easier? It doesn't become easier just because you've been around it more. It becomes easier because you're able to help the process be okay for the people involved.
The more the family is involved in a person's care, the better. I enjoyed having my family around whenever they were there. And I think the patient gets well sooner if the family is there.
As we decline, inevitably, family caregivers become extremely important.
I think the amount of family support is just so huge for especially the patients that I see because of their acute change in their situation. And it's, it kind of breaks your heart when nobody has anybody around to help them.
We all sort of believe that we're never going to have to be a caregiver. And yet, as it turns out, actually more than half of adults will end up being, pretty much full-time caregivers at some point in their life for another adult.
Now you've got people that live all over the country, and a lot of patients are very much alone, and they don't have much support system in terms of family locally.
As more and more of us age, and more of us are around, and more of us live to a point where we will have some form of disability, the need for caregivers in that way will expand even more than they are now.
We're looking at really an increase in the number of people over the age of 65 that we've never encountered before in the history of the world. And so there's really no precedent for how do you deal with this as a society.
We're going to, they estimate, need 30,000 geriatricians. Current predictions are we may have somewhere between 7,000 and 10,000. And one person can't do the job of three.
The pool of doctors that can deliver the care is shrinking because of the inadequate reimbursement mechanisms, and there's this growing aging population. I mean, there's the baby boom generation, so there's a lot more of them, and we're living longer.
In virtually all of the adult specialty and subspecialty training programs and practices, they're seeing an increasing number of geriatric patients. And they're dealing with the comorbidities and the complexities that go along with that demographic.
With the aging population, everyone is going to take care of the elderly.
Right.
The neurologists are going to be experts in diseases of aging. Cardiologists are going to deal with more and more aging. We're going to deal with cancers in frailer, sicker people, and everyone's going to have more knowledge about the basics of the care of the frailer 75, 85, 90-year-old.
Primary care doesn't get reimbursed very well. Students are coming out with huge debt loads, as you all know.
It's hard to accept a job making significantly less money when you could get another one making a lot more money when you're facing that kind of debt, especially.
The specialist can go and do a procedure and get paid, a fairly large sum of money, right, and do it in a fairly fast amount of time, whereas my 90-year-old patient who may have, 15 different problems on their list, we may spend an hour doing really important, complex care, and the most important thing I might do is stop 2 medications on their list and make them quit falling,
right, and
reduce their fracture risk, and I might make a tenth of a procedural charge.
If it's about the money, I guarantee you it'll never be enough. It'll never be enough. If it's about power and parking places, I absolutely guarantee you it'll never be enough, because you'll never get close enough to the front door. But if it's just about fulfillment and what you do every day, and going in and out of that clinic room, one patient at a time, and you feel good that they're walking out feeling pretty good about that intervention they had, even if they know they're dying, even if they know that they have an incurable illness, even if they know that you can't fix their hip, but they feel very good about the intervention or about the discussion they had with you and about the relationship they have with you, then you'll be happy, and it'll be a success for you. And the rest of it will follow.
We have some doctors who are totally open, who are really focused on you as a whole person, who will ask questions, who will give you time, who will listen, who will feel.
When you've been in practice for a while, you develop relationships with patients. And in the older patients, you especially have relationships with them because some of them have been with you for 10, 15, 20 years.
And I remember a lovely lady in her late 80s from Unionville, Missouri, who had a disease called bullous pemphigoid, which is an immunobullous disease, pretty serious, where older people get big blisters all over their skin. And I was able to manage her on some pretty dangerous medicines at a distance over time. And I remember toward the end of her life, our last visit, she made an appointment just to say goodbye to me because she knew she was getting ready to die. And all the issues were resolved. Really, she just wanted to say goodbye to me. And I never met her in person, but we certainly had a real relationship.
One of my fondest recollections involved an older Japanese American gentleman who came in, it's probably been 5 years ago now, with a ruptured aneurysm in his early 80s. And he spent pretty close to a month in the ICU, so I got a chance to know him and his family quite well. And he now comes back generally on an annual basis. He's now 85 or 86. And I mean, it's a great reunion when we see him. So I've given that gentleman, in a sense, some extra years of life, because he would have surely died from his aneurysm. And it's just a connectedness that you just get with that kind of interaction.
It's very hard to describe. But it's that warmth that you have, knowing that you're having a positive impact on somebody like that, who recognizes that you have limits in what you're going to be able to give them from a medical standpoint, but recognize that you have this boundless and limitless offering in terms of what you can do for them as a human being, one human being to another.
I like to make evening sort of tuck-in rounds after the hospital was quiet, and I like to go around and talk with the patients. And there was a woman that I don't remember her name, but we had admitted her the day before. She was kind of pleasantly demented, and so I went in with her. It was evening to just ask her how she was. I sat at the edge of the bed, and we talked a little bit. She had no particular concerns. She asked if I could pour her a glass of water. May not have even known who I was in the total scheme of things, but I was happy to do that. And as we were ready to go, I said, "Is there anything else?" And she said, "Will you kiss me goodnight?" And it still moves me a little bit when I think about that. And I thought of all the times I'd asked my mom to kiss me goodnight, and when I kissed her goodnight on her forehead, I just thought what a gift that was, just to reorient me to the humanity in all of us, and how it doesn't matter which side of the bed we're on, we're all the same. I think in the end we're pretty selfish people in medicine, because at least maybe in family medicine, because I think we get so much more back from these people we get to know, from the lives we get to be a part of and glimpse, than we potentially ever give.
We're a little piece of somebody in somebody's file. Whereas years ago, when life really just started for me as a mother and a wife, we had a doctor, we had a family doctor. The family doctor knew if my son cut his finger, if my daughter had a bad running nose. He knew us as personal people, not just somebody who came into the office. Today it's a whole different feeling, and I wish that family feeling could come back.
I knew that I was close to death, and of course I later was told that. And it sounds trite, but I still to this day, 20 years later, will realize I'm lucky to be alive. I'll look out the window at the sun and the trees and say, oh boy, I didn't know I'd be here.
81, that's a pretty good age. I've reached that, so I know that I won't have much left of my life, and I want to make as much of it as I can while I'm still here.
I look back at the whole experience. My wife, well, fabulous. My children, the choices I made. I feel that they have brought me to where I am. So I can't say, even though I would like to say from an ego standpoint, geez, I wish I'd have done better or more or something. I have to look back and say, God, if that's the whole thing's a miracle.
Yesterday was my birthday. I am 93 years old and looking forward to several more years of good health, good mind, and the joy of my family.